Look at this diagram comparing two types of head pain. On the left, you see a standard tension headache, a dull, band-like pressure squeezing both sides of the head. But on the right is a migraine. This is a severe throbbing pain, localized to one side, radiating along specific nerve pathways. A migraine is a complex, debilitating neurological event. The root cause of that localized pain lies deep within your biology. If you suffer from migraines, your brain's sensory nerves and the surrounding blood vessels exist in a chronic state of hyperreactivity. Your nervous system is hardwired to overreact to stimuli. That genetic baseline is always present, but the attacks themselves require a spark. We call these external sparks triggers, specific changes in your body or your environment that ignite this hyperreactive system into a full-blown episode. Internally, these sparks often come from physiological shifts. A sudden drop in estrogen, a disrupted sleep schedule, or even mild dehydration can trip the wire. Externally, the environment plays a massive role. This time-lapse captures a sudden drop in barometric pressure as a storm rolls in, a common weather trigger. Add in exposure to glaring bright lighting or high humidity, and the nervous system is easily pushed past its threshold. Distinguishing between the unchangeable neurological root cause and these controllable external triggers is the mandatory first step in treatment. You cannot change your genetics, but you can learn to manage the sparks. This diagram maps out the multi-day progression of the disease. A migraine operates on a strict timeline, unfolding across 4 distinct phases that can span up to 3 days. Phase 1 is the prodrome. Hours or even days before any pain hits, the body sends early warning signs. You might experience intense fatigue, uncharacteristic mood swings, or sudden cravings. Next is Phase 2, the aura. About a third of patients experience a wave of abnormal electrical activity spreading across the brain. It disrupts the nervous system, causing temporary visual blind spots, flashing lights, or tingling in the face and hands. Phase 3 is the headache itself. This is the peak, lasting anywhere from 4 to 72 hours, characterized by severe unilateral throbbing, intense nausea, and extreme sensitivity to light. At this moment, small proteins called CGRP, which transmit inflammation and pain, are flooding the nervous system. Finally, Phase 4 is the postdrome. The pain eventually subsides, but it leaves the patient in a state resembling a severe hangover. Lingering cognitive fog and deep physical exhaustion can persist for another day or 2, preventing a return to normal life. This 4-stage anatomy shows it's a systemic hijacking, not a localized headache. Effective treatment requires intervention throughout the cycle, rather than just masking the pain at its peak. The biggest challenge in treating this disease is that it is entirely invisible to traditional imaging. Run an MRI or a standard blood test on a migraine patient, and the results will look completely normal. Instead, doctors use this specific layout, the ICHD-3 clinical criteria. They evaluate the patient's symptom pattern against these strict requirements, checking for details like the unilateral location of the pain, a pulsating quality, and the presence of nausea during the 4-stage timeline. To build that pattern, patients use a migraine diary. Tracking daily habits and symptoms helps doctors isolate the unique environmental and physiological triggers that push that specific patient over the edge. Clinical pattern recognition provides a measurable, treatable diagnosis for what was once only subjective pain. Modern treatment follows a dual strategy, defending the biological baseline and extinguishing an active attack mid-cycle. Defending the baseline starts without medication. It means establishing consistent sleep schedules, maintaining daily hydration targets, and actively managing stress to keep the nervous system calm. Patients can also use drug-free neuromodulation devices. As you see here, these devices send precise electrical pulses down nerve fibers, physically altering the signaling to disrupt the migraine cycle before it peaks. When an attack breaks through, doctors deploy abortive pharmacological treatments. These are immediate response medications like triptans, high-dose NSAIDs, and rapid-acting nasal sprays designed to stop a Phase 3 headache as it starts. But while abortive treatments and lifestyle defenses are crucial for managing those sudden sparks, they aren't always enough. Chronic sufferers need a systemic shield that stops the cycle from starting in the first place. For decades, preventative migraine care was limited. Doctors had to rely on blood pressure medications or anti-seizure drugs, treatments that took months to work and often came with heavy side effects like cognitive fog and intense sedation. In 2024, the American Headache Society updated their guidelines to move a new class of treatments to the front line, CGRP inhibitors. This diagram illustrates how they work at the microscopic level. These new preventative medications, known as gepants and monoclonal antibodies, are specifically engineered for migraines. The Y-shaped molecules intercept and block CGRP pain transmission proteins, locking into the receptors and stopping the timeline before phase 1 begins. The medical toolkit is still expanding. We now have highly targeted preventative tools, like the precise ART Botox injection protocol, and clinical trials are advancing a new class of PACAP inhibitors for patients who do not respond to CGRP treatments. By mapping the chronological timeline and tracking individual triggers, patients can now use targeted therapies to stop the pain signal at the source. The condition is no longer a mystery to be endured, but a biological process that can be interrupted.